So good morning. It is an honor for me to introduce my friend, colleague, and compinche, Dr. Mirella Diaz-Santos. I will very rapidly tell you about her academic trajectory, but I will take a couple more minutes at the end to tell you some of her accomplishments, which you cannot find in her CV. Dr. Diaz-Santos completed her bachelor's degree in psychology at the University of Puerto Rico, Rio Piedras, her clinical psychology, neuropsychology doctoral degree at Boston University, and postdoctoral fellowships in clinical neuropsychology and neurosciences at UCLA. At UCLA, she received an NIA diversity supplement with the Human Connectome Project, Aging under the mentorship of Dr. Susan Buchheimer, to study bilingualism as a mechanism of brain and cognitive reserve against Alzheimer's disease in Latinx healthy older adults in Southern California. During this study, Dr. Diaz-Santos developed and implemented a bilingual, bicultural educational outreach program offering community members and community partners culturally and linguistically congruent education about Alzheimer's disease prevention, diagnosis, and treatment. These efforts led her research towards a pilot study with UCLA's Research Centers of Minority Aging Research, RICMAR-CHIME, where she's currently employing qualitative research methodology to understand Latinx family-centered decision-making processes leading to research participation acceptance or refusal in Alzheimer's disease clinical trials. Dr. Diaz-Santos is the director of the Equity for Latinx Hispanic Healthy Aging ELA lab at UCLA Mary Easton Center for Alzheimer's Disease Research, with a focus on prevention and early detection, diagnosis of Alzheimer's disease and related dementias in Latinx communities, and is the director of Minority Outreach Initiative at UCLA Stacklin Center for Cognitive Neuroscience in the Department of Psychiatry and Behavioral Sciences, where she is partnering with researchers to reduce barriers impacting research participation of historically marginalized communities in neuroscience studies. Wow. On a personal level, it is worth mentioning that as a woman of color in an ultra-competitive academic medical environment, success is dependent on a lot of grit, hard work, excellent mentors, a champion, and at least one colleague of color who can really help you carry the burden. And Dr. Diaz-Santos has been that person for me. I mentioned this not only, I mentioned this because not only has she made incredible strides in reducing health inequities as a clinician, educator, and researcher, but she has played a key role in keeping me and other women and students of color who work at reducing health disparities in the game. To this end, I would like to put a plug in for the first anti-racist neuropsychology course, which she has carefully developed to give students a voice, because that is what Dr. Diaz-Santos does best. She makes sure that her patients, her students, and her colleagues from underrepresented backgrounds have a voice in academia. She also has been the leader of a very successful mentorship program for the Hispanic Neuropsychological Society, and within the HNCE here at UCLA has worked tirelessly and donated hours and hours to make sure that our students present at our national conferences, some of which receive presidential mentions. I would like to end this introduction by inviting you all to read her most recent published article titled Alzheimer's Disease in Bilingual Latinos, Clinical Decision-Making and Diagnosis, published in the Journal of Health Sciences Psychology, which in a few months turned out to be the most downloadable article in the history of the journal. Take it away, Doctora.
Gracias, colega, por esa introducción. Thank you so much to all of you that are present and to all of you that are over Zoom. So I invite everyone over Zoom to just chat, ask questions. We have the amazing Amy here assisting with the chat, so feel free to engage, because I think that the goal the intention for today, and you saw the learning objectives of today's presentation, is we want to talk about brain health equity, right? But we also want to talk about all the other aspects of, methodology, science, and current practices that I have observed throughout the years that actually hinders health equity and perpetuates health disparities in our communities. And I'll be talking specifically from the Hispanic, Latinx, Latino, Latina communities, because that's part of my own identity. Yo soy puertorriqueña, I'm native speaker, came to the States for education, so I'm a first generation. So it's surreal that after so many years as a fellow, I came here in 2015, and now in 2022, I'm here in Ground Round. So I wanna say thank you to Erica Bath and Jonathan Hayes for the invitation. It doesn't go unnoticed. And then you'll see that everything in my presentation will be framed within the Alzheimer's disease research program, because that's one of my areas of expertise. For those of you that already know me and have seen Nibble, which is the neuropsychology launch, brown bag, I use the pedagogy of Paulo Freire with the aspect of conscientización. So that's the aspect that I'll be engaging with all of you today. It's like, I don't want to engage in a banking education format. I want to be engaging in a problem posing education where I'm not the expert, like the reality gets uncovered by more people having leadership positions, because we have a lot of nuances that are never discussed if the people from those communities are not involved in that conversation. So that's why I invite you all to engage with me with this journey. So you'll see that today's presentation will be a lot of process. You'll see a lot of content for the purpose and intention of engaging you in critical conscientiousness, right? So because in terms of health disparities, we know, and there's a lot of literature and a lot of philosophy and theories that talked about, in order to make actions applicable in that actually has an impact on reducing health disparities and more health equity, we need to make sure that we know the world from this different perspectives. So you have to name it, and then you have to reflect on it, right? And no one can name the world for anyone else, but that's unfortunately what happens constantly, right? So with that being said, so when we're talking about inclusive science, this is a paper from the senior author, Dr. Norris, who is a faculty member here. You can see all the components associated with an inclusive science. So I think that this is where my colleague, Dr. Suarez, was mentioning that in order for us to have inclusive science, we have to have all of us in the leadership position, in positions of power, and in a setting where leadership actually values our contribution, rather than just us meeting the quota and be like, oh, we have a diversity voice, but that voice has no power. And and we have been here in academic medicine for a long time to know that this happens pretty often, right? So that's why I have been working extensively to engage our community members, to engage our students, our faculty, and hopefully that's one of the goals that I'll be accomplishing today. So when we talk about inclusive science, what's the point of it, right? So we talked about, and this is just briefly, there's always the opportunity of inclusive science because we need to figure out and think clearly, like what is like the aspect of internal or external validity, right? And how inclusive science actually makes better science, right? Because I know that a lot of the things that we do in scientific rigor, we always talk about randomized controlled trials, which are very, very important, right? But in a randomized controlled trial, what happens? You have to control for everything under the sun So then you can study the mechanisms, and mechanisms are very important, right? But what's the downside? Like we know, so if you focus on internal validity, external validity will be compromised, right? But then you have this narrative of course, we have to do internal validity, RCTs, because it's very important. But then when we're talking about implementation, the aspect of, okay, now let's go to the different communities to implement and the aspect of effectiveness, what happens mostly? They don't fit. They don't fit, right? And so why is it that it doesn't fit? So when we're talking about science, we know, like think about all the projects that we have here in psychiatry, neurology, all throughout our institution here at UCLA. I'm talking about the real samples because this has already been disclosed. We have been talking about it, where our research is dictated mostly by the sample that we recruit. The science that we perpetuate, that we implement in clinical science, in clinical practice, in our teachings are always dependable, not only in literature that creates the design, but also the research samples that we recruit and retain. And the literature says that most of our research samples are weird in the sense that they're Western, educated, industrialized, rich, and democratic societies. And then in terms of the aspect of neuropsychology, cognitive testing, this is, bless you, this is something that we have been discussing, right? A lot through the years. Think about all the research articles that you have read. In the patient or research sample demographics, what is it like? Do you see a good description of the research sample dictating the results? Exactly, right? And then we have some for a very long time and still did to this day where the research samples that dictating the result are mostly men, right? So bear with me with this self-reflection. So when we're talking about weird samples to universal claims, we know that we're talking the paradigm of universalism, right? Everyone has a brain. Everyone has emotions. Everyone, so everything like, oh, no. So we need to think about, general ability, like everything is general because we are all human beings. And then all these contracts are valid regardless of the culture, the context, the language, and so forth, right? But what happens when we have a very systematic way of where policies and laws are placed in a system that the lived experience of different communities is completely different, right? So I'm speaking to the choir here, hopefully, because like with the COVID-19 pandemic and the political arrest and everything that we have seen in the news, we have seen this, at least from even in my own education, more conversation about what are social determinants of health, right? Nursing, public health, implementation science, this is part of the curriculum. It was never part of my own curriculum in clinical psychology, right? So I studied the brain in a vacuum and didn't know about social determinants of health, right? So, and what are the social determinants of health? Are the environments where people born, live, learn, work, play, worship, and age that affect a wide range of functioning, quality of life outcomes and risk. And then you can see here all the ones that are already disclosed by the Department of Health and Human Services, the CDC, and recently now with the Alzheimer's disease and related dementia, they are talking about built environment access to healthcare. So let's think about UCLA and healthcare access to our communities of color. And the crucial aspect of loneliness or social isolation with the pandemic, right? Who has access to Wi-Fi, who has access to computers, who has the privilege of actually being at home and being able to engage with educational or work-related events through the web, right? So it's not the same for everyone. So that's the part of what's brain health equity, right? CDC defines as when everyone has the opportunity to be as healthy as possible. And you can see here from the graph of CDC, you have different components, right? The programs, the measurements, and then indicating policy, but everything is related to that infrastructure. But what we know is that that infrastructure is still not in place, right? And that impacts the programming and the measurement. So bear with me here. So if we at the organization, federal, national, state level are committed to brain health equity, so tell me why our research samples are still weird then, right? So during the COVID-19 pandemic and everything that has transpired, and more recent media coverage of the disproportionate and unjust treatment of our communities of color, now we can talk about actually structural racism, you know, and I can say racism without being scared for my own livelihood. Because before, like anyone will talk about racism, and we still see and hear of new cases of scholars and professors that actually are, you know, fired for having these conversations, right? But I know that here in psychiatry, we have a commitment, so I feel, okay, I can talk about it. And hopefully no one will make a complaint, and then that will put my position in jeopardy. So why are our research samples still weird? It's like, well, we have to go back to history. And I'm not a historian. I consume history, but even the American Psychiatric Association last year made that statement and recognized that the use of our communities, that they were subjected to abuse, treatment, experimentation, victimization in the name of scientific evidence, along with rationalized theories that attempted to confirm the deficit status, right? So there's a long legacy of academic medicine of using science to justify the deficit status and then create these programs that justify segregation and so forth. And for those of you that have been enabled in my class, and I invite you all, so when you see nibble, just know that that's me being annoying to everyone, sending those emails. So this is the face responsible behind those emails, because this is where we're talking about all the nuances, all those hidden factors in front of our faces. And we have had the pleasure of like even having our amazing colleague, Dr. Enrico Castillo, talking about redlining and how that the impact of health outcomes of homelessness and mental health. And even our colleague, Cecilia Menjivar, she's a sociologist in North Campus, and she talked about legal violence, right? And then the impact of mental health outcomes on immigrant Latinas. Because with her research, we actually learned in class that they, in Kansas, they are ways that is still violence against our community of color, but they're still legal, right? So like checkpoints, racial profiling, like when they're all their checkpoints that around the city in the middle of downtown, that's where most of the medical and mental health clinics are located. So if we're talking about immigrant communities, they won't pass those checkpoints because they will be deported, right? So when we're talking about concientización, it's like, why are science still weird? These are the factors that we want to talk about and reflect, as well as in this amazing book from our colleague in public health, Chandra Ford, and I recommend for all of you to get it. So when we're talking about all those aspects of of social determinants of health, structural racism. Okay, so what's the impact on the science of recruitment and retention? So my colleague, Dr. Suarez, mentioned that one of my champions here is like Susan Bruckheimer, and we work on the Human Connection Project for my diversity supplement. But I quickly learned that our typical recruitment and retention practices of just having a flyer, just putting it around Westwood, it doesn't fly, right? It doesn't fly. You will get the typical, still weird sample. So what we did, I'm like, as a junior faculty at that time, I took the rest of what's available out there, even at the national level, doesn't have an equitable representation of Hispanic Latinx communities in their sample. And I wanted to know why. I think that this is where my narrative, storytelling, I need to understand what's happening, persona comes into fruition. And I wanted to experience it by myself. So what we did, we implemented all the evidence informed strategies. And I know this is not rocket science. You partner, you have congruent team members, and then you do the typical mailing list, clinical registries, snowball sampling, and just having a demographic targeting flyer. So this is where all my career, and many of you have seen this, kind of took a shift, because this is where I started learning, okay, this is not the community. This narrative that I have heard so many years, all the communities are not educated, they're not interested in becoming part of science. I started debunking that hypothesis, because what we did intentionally created a bilingual and a bicultural educational programming with the brain health. We talk about sleep, we talk about stress management, nutrition, and we translated the science, took out all the medical jargon that we are so proud of, but the community doesn't quite understand, and then started engaging with them in dialogue. And then with that, also talked about, what's the role of science in all of that, and how can they feel they can contribute to that aspect of empowerment, right? So if our communities are not actually interested or not interested or in participating in research, this data right here proves that hypothesis wrong. Because we raise awareness, and this was pre-COVID, and out and about in all throughout 2 years, and we were able to gain the interest, the willingness to participate from this amount of community members of 50 years and older, right? So obviously you have that, some of them that provide the contact information and don't want to engage with the coordinator, but look at all the green numbers, right? So when they contacted the coordinator, and the coordinator, who was an amazing Marcela Caldera, who is now in pre-med education. And this is what we found. At this time, I didn't have, as a postdoctoral fellow, I didn't have any power on the study design. So it was, and this is a U grant, but all the protocol was in English, right? And this assumption that I have heard, well, if you live in United States, you should speak English. And so those universalistic assumptions are always transpire in the research design. So this is why inclusive science is so important, because this meant that a lot of people that could have potentially been a good fit for the study were automatically excluded because Spanish were the first language, and we have no protocol in Spanish. So they were excluded automatically due to language, and then the screeners are also in English, and then the aspect of inaccurate ethnic representation, right? Because we have at the structural level, we have organizations dictating how people to categorize themselves. And don't get me started with the whole debate of Hispanic, Latino, Latina, Latinx, Latinx. And there's a lot of debates and a lot of time invested in this debate. But then when you go to the communities, they just want it to be called tú eres Latino, tú eres Latina, tú eres Mexicano, tú eres Puertorriqueño, and that's about it. However, those in leadership, they want to categorize us in a way that is consistent with their own preconceived notions. So this is also impactful. But then, and then this part right here, this is where you talk about family dynamics. Some adult children feel very uncomfortable having their parents engaging in a neuroimaging blood biomarker study. And although the older adults were interested and they were wanting to engage, I was like, well, I spoke with my son, I spoke with my husband, and they are not comfortable, so I'm withdrawing. And the aspect of when we talk about access to healthcare, for an neuroimaging study, what do we need? We need MRI safety. So if you don't have information about the implant, you are automatically excluded. So a lot of our older adults and a lot of community members, they go to the country of origin in Latin America, Mexico, and so forth to receive care. So that's also impacting. So keep thinking about all the barriers that are systematically in place that literally impact recruitment and retention, and then the science that we generate. So with that, this is what we've learned from this study. That even though the most cost-effective, efficient, and highest interest turnout was direct community educational outreach and engagement, right? All of those, the vast majority of those individuals were completely excluded, right? So who did we retain? We retained those from mailing lists at UCLA, clinical registries, and referrals from UCLA employees. So who did we retain? We think about the study methodology, all bilinguals or multilingual. Most of them identify as white Latinos with higher education and middle to high income level neighborhoods. So what we know at the NIH level, they were like impressed, and I'm like, thank you for increasing the representation of our Latino, Latinx, Hispanic communities. But this sample is not representative of our communities here in Southern California, right? So what did we end up with? The equivalent of a weird sample, but we call it a weird Latino sample, right? And this is the science dictating still the mechanisms, the RCTs, and then what gets transpired into treatment planning or treatment studies. So what did we learn too? We learned that there's a lot of practices that are ongoing, and I hope that I can engage with all of you in this one because I feel that this happens too often, and I would love for just to stop having this conversation. When we talk about measurement, if you do in-home translation, if you hire the language and culture congruent RA, excited to be working to do all of your translation, that is not science. Let's just call it like that way. Let's call it. And this is something that I continue to see all the time, right? So we're talking about validity and reliability. One thing that I have noticed is that when we're talking about health equity, it's like, oh, we want to work and be more inclusive, but then for some reason, the scientific rigor goes off the, like, se va por la puerta. It's like, literally, it doesn't translate, right? We learned that culture obviously doesn't translate with language. The whole conversation is like, oh, we just need to make it only in Spanish. It's a great first step, but if you Google Translate, everything into Spanish, and I know that happens pretty often, that's still not scientific rigor, right? And then the aspect of culture doesn't translate with language. So if you're not using cultural components, cultural priming, you you will literally, the community is very attuned to how much effort you're putting into what you're giving them. And if they notice that you're just one of those in the scientists that literally just want to collect data and leave, and you represent UCLA, that will also transpire into everything that you're doing, right? And we learned that experts in health equity are not often included in grant writing and study development and execution. So this is from this study. For the RICMA study, we kind of wanted to unpack what we learned qualitatively, and this is where I started working with my mentor, Gerardo Moreno in family medicine, Efraín Talamantes in Alzheimer. And what I learned with them is that the participating or engaging in anything requires decision making. It requires multiple stakeholders, right? And when we talk about stakeholders, it's not only the individual that we're working with, right? We're working with study coordinator, caregivers, family, adult children, community members, but we're also working within the framework of your decision, your individual decision is also contingent to family and your culture and your community, but also to all those social determinants of health. Because if you don't have time to engage with research, you might be interested, but if you're working 2-3 jobs and are like essential worker, and if you won't engage for more willingness that you have to be part of science. So during this study, as Dr. Suarez mentioned, I wanted to know what was the role of the caregivers and the family of engaging themselves and the patient, the family member with Alzheimer's in this type of research. But obviously then COVID-19 hit, and I didn't feel that I was, I didn't feel right to be asking caregivers to like these questions when they are suffering so much. And I do run a caregiver support group every Monday over Zoom during the pandemic, and they are suffering beyond measure. We have members that have lost their loved ones during the pandemic, and there's a lot of trauma, and a lot of grief. And I was like, I don't feel okay with asking this question. So what I did was I focused mostly in the community stakeholders, because I thought that community stakeholders will have a crucial decision in engaging our communities. What I learned was very surprising to me, but actually it makes sense. I conducted 12 semi-structured interviews. And the message is that our Latino caregiver, like our Latino community stakeholders, are often excluded from these conversations. I was not expecting that. I wasn't expecting that at all, to be honest with you. So the level of exclusion goes extremely deep, right? So they might have, you might have one diversity, the diversity of voice in leadership, but even when you're in that position, you're not even valued. So that created a lot of this disconnect between the agenda of Alzheimer's disease research and what actually the community needs currently with aging and Alzheimer's and so forth. So that was the overall message. When we're talking about the themes that run through the interviews, this is what I found. Our community stakeholders, I actually use as translators, as only administrators. And this is where they find out that the translations or the instrumentation made no sense to them, or when they were administering them. So they would tell me, well, I had to explain to them the instrumentation, but I couldn't because I had to follow the protocol. So the community members or the research participants were completely confused with what exactly were the instrumentation asking. So now think about what the data tells you. Because at the end of the day, if the Latino community stakeholders are not part of the leadership conversations, it means that those lived experiences during the administration are not trickling up to leadership, but leadership is still collecting that data, right? And still publishing, right? In the outcome. So what's the quality of that outcome measure? And a huge one, find me your people. I've been there. I continue to be there. So I just find me people, like where can I find Latinos? And I'm like, just look up and you will find them, honestly, like any other community member. And then this transplant kind of like had this continuum of exclusion practices where you have language isolation. If all the instrumentation is in English, you're creating isolation. If you're not using cultural adaptations that are congruent with the community that you're working with, you're creating cultural isolation. And then you're also creating structural alienation because they don't feel connected with you nor the research. And one aspect fascinating that I found in the interviews was that all these non-inclusive practices actually triggers cognitive schemas. I have a PhD in clinical psych. So cognitive schemas about trauma, non-belonging, right? Which perpetuate that's like, okay, I don't belong in research. So if you think about all of that, I hope that you can already understand what's the narrative here. Because if our communities are already excluded by government, by programs, because apparently you have to be earning $20,000 a year to be eligible for things or less in LA County. Immigrant communities, which are huge here in Southern California, are having a hard time navigating for basic needs and getting their basic needs. And they might be willing to just say, like, let me just learn a little bit of research. And then they continue to get the same message. It just continue to trigger that cognitive schema. There is a valid schema, right? Those negative beliefs. So that talks about when we talk about measurement. So hopefully by now you already have a quite understanding of how measurement can be impacted by our leadership and who's at the table. As Dr. Suarez mentioned, I came here in 2019 for my clinical fellowship. Right now we have the HNCE and all these amazing programs. And I just wanted to highlight this aspect of the question. So when having problem posing exercises. So I know that we have now psychologists here in the room. When we talk about WIMS 4, what's the story of logical memory?
Verbal memory test.
Mm-hmm. Right. So logical memory of WIMS 4 was the cultural prime, the priming. ¿Cómo es la historia? Right, isn't it prime? Anna Thompson, doctora? No, it's something priming Boston. Like South Boston and I think, right. So I know Boston because I went to BU for grad school. Okay, for our communities, like if you haven't heard of Boston or Anna Thompson, right? How can you encode that information if it makes no sense to you? However, the ROT score will convey that you are not encoding nor retrieving that the sufficient information. And then when you have your skull score and so forth, or T-score, that's like, oh, you're deficient. Therefore, there's something in your brain. I'm bringing this story up because when I was a few years ago before the pandemic, I was in a meeting and it was clinical trials and Alzheimer's disease. The literature made the decision to use the WINS-4 logical memory as the screening tool for inclusion of the clinical trial. And I was like, I wonder who made that decision. There were neuropsychologists, I'll call it as I saw it. There were two white men making that decision, right? And I'm like, no wonder, how can you be utilizing the logical memory, which hasn't been validated with Spanish speakers? We have other instrumentation that are more valid, and that impacts include like recruitment and retention, right? So I know it's 11:44, so let me see how I can do this. So I will just go because I would love to leave some time for conversation. So in here, I kind of like summarize a little bit of my work with, our colleague with the HNC, with a lot of amazing trainees, and understanding how social determinant of health actually leads to exclusion of clinical trials continuing, but I'm pretty sure that you already kind of have a feeling that how is it excluded. I do want to highlight the aspect of divergent clinical phenotypes of dementia with all these conditions, neurological conditions. But this is the part that I want to highlight. When we're talking about neuropathology in Alzheimer's disease, we have the tau and the amyloid beta hypotheses, right? And now more than before, we also have the vascular inflammation hypotheses of how it contributes. But a lot of our medications are still in tau and beta amyloid hypotheses. What's the implication of this? When we're talking about social determinants of health, racism, discrimination, air, water, access to healthcare, and all the ones that you saw, you have the HPA axis, you have inflammatory markers, we have vascular, and now we have COVID that also taps into inflammatory and vascular processes. So when we talk about neuropathology and the aspect of clinical trials, the amyloid and tau hypotheses, a lot of our community members are completely excluded again, because what I have heard, they're too messy. They're too messy. They have too many medical and psychiatric conditions, and we need someone clean. So someone clean means internal validity, right? But that impacts every single community, because how many are only solely like clean cases in the early stages, right? Those that have access to a lot of things, including healthcare. So I'll end with this. So in the past couple of months, I continue to ask the same question. Why are our Latinos, Hispanic communities are not equally represented in research? And this has been my journey here with my lab. So this is what I wanna, let me see, here we go. With the work of my amazing research assistant, Stephanie Olivero, we started asking the question of the digital divide, because with everything with COVID-19, everything has been moved to Zoom and web. And so, like right now, how many do we have in Zoom? How many do we have in person? Right, but that assumes that everyone has access to computers, to Wi-Fi, to good Wi-Fi that supports Zoom, right? So we wanted to know, and we work with a lot of the Alzheimer's organizations and community members, and they was like, oh, the communities are not attending this education programming for brain health equity. So why they're not using? So Stephanie created this, this model of digital literacy to unpack accessibility. And again, the social determinants of health and language, right? So this is what she found. After exploring 16 organizations here in Southern California, this 31% is 5 sites only that only have information available in Spanish. This 31% is the same, 5 of the 16. Accessibility to tools of being able to navigate the website. Website navigation is extremely complicated. And she spent like 2 months trying to do this work, and she has a bachelor's degree here at UCLA in anthropology. And then 2 only had Alzheimer's disease dialogue resources. None of them had share criterion. So those that were in Spanish didn't have the navigation and so forth. And then she also found this part. The telephone numbers, and this is where I love the exercise, and I hope that he's hearing Dr. Castillo, that of structural interventions, because he has this amazing exercise of calling, right? Calling those community resources like, oh, he will, right? And it's nerve-wracking, but these are the pamphlets that we give our community, like our patients, and then we call them, and then what do we find out? That's sometimes they're not even working. So we found the same thing, right? We found the same thing, or we found that when we talk about linguistic inclusivity, those answering the phone calls only spoke English again. And if you have, or even if you have more in-depth questions about the programming, the staff didn't have enough information to provide an informed, to engage in an informed conversation, right? It's more like, oh, I'll call my supervisor, I'll call you back. We're still waiting for that call back. So now think about that. This is the landscape of Alzheimer's disease research and resources. So if the resources are not available in Spanish, or someone that is knowledgeable to have this conversation in their primary language, how can we expect to diversify our research samples? And then she engaged in understanding more of the dementia continuum. And what we found is what we already knew, but now we have more data, that the healthcare system is completely broken. And a lot of the programmings that were in before pandemic, we had only a few, but many of them didn't survive actually the COVID-19 pandemic. So we don't have a lot of programs in Spanish anymore, right? So when we talk about health equity, brain health equity, and how our science continues to be weird, I wanted to know what was the landscape, right? And these are part of the research questions that I have for my lab, in order to have a more informed decision of like that informed action of what is it that the communities are actually in need of, right? So right now we're developing programs of social isolation and loneliness in Spanish and cultural congruent with DMH. We're like creating community coalitions. We're doing a lot of educational programming, following community participatory research methodology or research approaches, implementation science. But the thing that I wanted to close today is from a selfish perspective, it's like, I cannot do this by myself, right? So I need to engage as many of us as are willing to do this work together, because our communities are completely in need and they want the services. But if we are not aware of our own privilege or imposing our assumptions of how things work, and I have engaged in many dialogues with stakeholders that have this kind of like, oh, we're here to save the communities. It's like, it's just it's heartbreaking for me. So that's what I hope that I was able to engage with you today. And I want to acknowledge all my academic partners and community, my mentorship team, and the founders that have been supporting my work so far. So with that being said, we have 7 minutes, right? Or 6. Thank you. Did you enjoy the world spin that I took you from? Questions, comments?
It does look like Susan Boheimer mentioned.
Hi, Susan.
She said, don't forget to note that thanks to Dr. Diaz-Santos's work, the renewal of the HCP-A now includes Spanish translation, Spanish speaking only subjects, and outreach led by Dr. Diaz-Santos to go deeply into the community to engage and include a more represented group of participants. So thank you.
Thank you, Susan.
Any questions from the audience while we wait for some virtual questions to come in?
Not all at once. Any reaction to the presentation? This reminds me of the old days when you had to wait for the microphone. Here you go.
Wonderful talk. Thank you so much for your presentation. I wonder if you could give one tip for folks that want to join you in this cause. What is the tip that you would give your sort of typical researcher? What can they do differently to make a difference aligned with the principles that you've outlined in your talk?
Like following, like I feel that even following the aspect of like class of nibble, understanding your positionality is extremely crucial. And this is something that we don't talk often in science, of course, in public health, in qualitative research. This is a common practice. There's a lot of literature on it. I don't see it as often here when we talk about neuroimaging, neuroscience, biomarkers, and so forth. So understanding your positionality is one, but it doesn't stop there. Because I think that in our experience, yes, we have had these conversations where researchers and providers, I'm like, well, I'm privileged. I come from a privileged background. This is my identity. These are like the axis of privilege and oppression, because we have a lot of intersectionalities, but literally stops there. And it stops there. And then when you look at leadership, the leadership remains completely homogeneous, right? So I think that the aspect of understanding your positionality, how it trickles down to everything that you do, including your science, is crucial. But also when we're talking about, okay, if we are about inclusive science, you need to be comfortable of getting uncomfortable, of having these conversations, and someone telling you, hey, by the way, the methodology that you're applying for this particular study, it actually might exacerbate health disparities. And then unpacking that together, including talking to the IRB, which is another component that I didn't touch on. The IRB doesn't have individuals from communities or that are experts in methodology of cultural and linguistic adaptation, which if they are the gatekeepers of our science, it also is an issue. So that would be my recommendation. Oh. Oh, I can see my screen. Okay, Susan. And Enrico. Hola, Enrico. Okay, I'm stuck with the dual problem of, on the one hand, remote Zoom. So much accessible, but on the other hand, having equity in internet. How could we address this? The public library system is widespread physically, but losing funding. Would be great to see into blah, 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 blah. So Susan, that's a great, and that's something that organizations are tapping into, because this is the aspect where I think that a lot of this cannot happen. So it loses funding because of lack of usage, and then funders want the deliverables, of course, but this losing funding because people are not using the services talks about their life experiences right now. So then you have that cycle. And I know that, like, I don't have a clear answer for that, because that's a huge problem in how all these community programs are actually losing funding. Doctora. Dígame. Oh. And while I get there, Enrico mentioned, should we be looking beyond papers, grants, and conferences to disseminate our science? How can this be built into our research infrastructure? So I think the aspect, one thing that I have been engaging in, and it has been possible, is with a lot of talking to communities, having newsletters, having journals, just like helping us translate the science in more consumable media outlets. And this is something that I have been working on, because I know that I had to be very honest, we suck at translating our science to our communities. Even when we talk about science to our parents, they don't even understand what we do. Right? So I think that that's a training that we should definitely get, or how to like translate our science into information that can be understood. Because once you understand that, you can engage. Doctora.
So this is less of a question and more, again, of a recognition of your work, which I forgot to mention in the introduction. So I'll try to make it into a question. I know that you have been invited to a very important occasion in Washington in the next couple of months. Can you tell us a little bit about that? And also, given that you'll probably have a couple of minutes, I'm assuming, what do you think is the most important message that you will take to Washington?
Okay, so because by nature yo soy bien bocona, so I have been engaging in, how do you translate bocona in English? Very outspoken. That's the polite way of saying it. So a big mouth. Is that I have been engaging in advocacy efforts at the state level, of like using my experience in Alzheimer's with my family, my maternal grandmother, how that transpired, and then what I have learned when I was a clinical fellow here at UCLA, and then when I've been working with the community. So then I had I've been taking all those experiences and say, this is why we need this money, but this is why we need leadership that is actually from our communities, because that's the message that I want to convey. Our gatekeepers continue to be non-part of our communities. And that's what trickles down to what our communities are exposed to, something that has no relationship to them. And then you're like, I have no connection to this science or these projects, then I don't engage. But then leadership and funders use the non-engagement as a justification for, oh yeah, they're not interested, I'm taking the funding out. I'll be at the Capitol, advocating with Alzheimer's Association for a few bills that are all about brain health equity. Okay, so that's all the time that we have. Let me see. Okay, Jeffrey. Okay, Jeffrey, I don't know if you're still here, Dr. Porter. Can you give some specific example how these cultural sampling errors have affected actual research results and conclusions? Has research shown that this is a difference? Okay, so I know this, we ran out of time. No, thank you. But this one is a hard question to answer because the research hasn't shown this, because at the end of the day, we haven't had much research on having been processing these errors. But what we do know is that there's a lot of diagnostic disparities because of these errors. Hope to have answered that question. So, okay, thank you.